Welcome back, MS2s. This is going to be a really fast ultrasound podcast to reorient you to some of the basics that we covered last year. So, jumping right into it, you got the probes. You've got three main transducers we went over last year: the curved, the linear, and the phased array. Recall that the phased array is the lowest frequency, so that's going to have really good penetration, but not the best resolution. It's got a small footprint. You can get between the ribs and look at the heart. The linear transducer is sort of the opposite of that one. It's got a very high frequency bandwidth, really nice resolution, but doesn't penetrate as far. And then you've got the curved transducer, sometimes called curvilinear, sometimes called abdominal probe. And it's a good sort of trade-off between a good frequency bandwidth, having a lot of elements in it, makes very beautiful pictures of the abdomen. So we use this for the kidneys, the gallbladder, the aorta, the pelvis, the bladder, things like that. And this here is sometimes called the vascular probe because it's that high frequency. Use it for superficial structures, of which vessels tend to be. So those are the three probes that we'll be talking about. The main planes of ultrasound: one is sagittal, indicator towards the patient's head. The skin line is up here, anteriorly looking posteriorly into the body. This is towards the head. This is towards the feet. And then coronal is sort of just like the sagittal plane in the sense that it's longitudinal. However, it's coming from the side of the body, indicator towards the patient's head. This would be lateral. The sound is being thrown medially into the body. This is superior, this is inferior, just like the sagittal plane. Talking about the kidneys, there's really two main ways to look at them. You can do an anterior or a coronal approach, sort of from that fast scan, Morrison's pouch approach. You can do it this way, or you can roll the patient on their side, a decubitus position, and look posteriorly there and get a view that way as well. This is what that anterior or coronal view looks like. You can see the upper pole here, the lower pole. This is the kidney, renal, pelvis, or sinus here. This is the cortex seen out here. Over here you can see a much shorter axis of the kidney. We're getting between the ribs, and sometimes we got to rotate the transducer to do that, so we're not getting as long as a kidney as we'd like to see, but we can see the kidney there just as well. Again, this is the renal pelvis in here, and the cortex is out here. And the left kidney, the liver's not as, I should say the spleen is not as big as the liver, so it's a little bit harder to see the left kidney. It doesn't get that nice window from the liver, so it gets chopped off a little bit. So sometimes you need to go a little bit more posteriorly and see what you got there. Now, talking about the bladder, there's really, like most things in ultrasound, there's two views. You can go transverse with the indicator to the patient's right, or sagittal with the indicator towards the patient's head. And in the transverse plane, we'll start there. You really need to get pretty inferior, as you remember. If you're going to see the bladder, you got to have the probe really inferiorly, and then you're going to aim inferiorly because it's really down low in the pelvis. And you can see here in the female pelvis, not only do we have the bladder, but we've also got the uterus and maybe the ovaries seen out here as well. The anterior cul-de-sac or vesico-uterine pouch should be here. The posterior cul-de-sac or recto-uterine pouch is back here. Now, in that transverse view, if you have an empty bladder, things get a little bit confusing sometimes. When you first look at this image, you're like, well, where's the bladder? I guess this is the bladder here. What's happening in that transverse plane with an empty bladder, the uterus is going out behind the screen and then coming back on top of the bladder up here. And as this clip plays, I don't know if you can get a feel for that or not, but here's the bladder relatively empty, and the uterus is sort of coming out. The vaginal stripe is down here, and then the uterus is going out behind the screen and then coming back out towards you on top of the bladder. And in the male pelvis, it looks very similar, except instead of the uterus, we have the prostate down here. This gets larger and larger as the patients get older and older, but you can see in a nice rectangular shaped, relatively full bladder in the male pelvis. Now, moving to the sagittal plane, the indicator towards the patient's head, again, you're going to fan down inferiorly. Sometimes we say heel-toe the probe, and so the toe is towards the indicator side and the heel is on the other side, so the inferior part of the transducer. So you're going to toe the probe somewhat in order to get down into that inferior part of the pelvis in a sagittal plane. Hope that makes sense. If not, feel free to ask me. Now, what you're going to see here is that first we're going to see the transverse view of the bladder in a male pelvis, and then it's going to move into a sagittal view. So here's transverse. We're looking at it nice, squared out bladder, and then they're going to rotate the transducer, which they are doing now, into a sagittal view. Bladder looks pretty similar, maybe slightly more of a rectangular shape to it, but that's the idea. Now, in a female anatomy, we know, just as a quick review here, things get a little bit, initially seem a little bit confusing, but with a little practice, it's all very obvious. So, whoops, go back here. This is the vaginal stripe that we see here, and the uterus is pretty anteverted here, especially when the bladder is empty. The uterus can get very anteverted, even 180 degrees back towards its vaginal stripe. Cervix is down here. The anterior cul-de-sac is over here, between the bladder and the uterus. This is the anterior cul-de-sac in here, and then you go around to the posterior cul-de-sac is back here, the recto-uterine pouch, posterior cul-de-sac here. And so the probe is over here, and it's shining the ultrasound beams. Again, this pubic symphysis gets in the way, so maybe the probe is like over here, shining the ultrasound beams down in this way. So you can see both the anterior and posterior cul-de-sac, and this is what it looks like here. Relatively full bladder, sagittal plane. I can tell because the bladder looks pretty triangular shaped. This would be the anterior cul-de-sac here. Looking posteriorly is the posterior cul-de-sac or recto-uterine pouch, sometimes called Morrison's pouch. And so there's all the structures seen there with a little diagram on it for you there. Vaginal stripe is this hypercoag line here that terminates at the cervix, and then the anteverted uterus coming up this way. Anterior cul-de-sac, posterior cul-de-sac back here. Good. So this is what it looks like when you have a really empty bladder. The bladder is actually over here. Hard to see because it's so empty. Vaginal stripe, cervix, and then the uterus wraps 180 degrees back towards itself there. And when the video clip plays, I think you get a sense of that sort of very anteverted uterus. Good. All right. Now, how do we measure the bladder? The bladder, you're going to measure it in three different planes, right? So you've got in a transverse view, I should say three different measurements, two different planes. In the transverse plane, you're getting one measurement, which is the height of the bladder here, D1 being the height. And then in the same plane, the transverse plane, you're going to get the width of the bladder. And you enter these values into the ultrasound machine, or you can jot them down. And then once you get that width, then you're going to unfreeze the machine and move the transducer from a transverse plane into a sagittal plane. And the bladder might get a little bit more triangular shaped, depending on its volume. When it's really full, it tends to be quite spherical. And so now you're seeing in the sagittal plane, we're going to get the third dimension kind of march all the way across the screen there. And that would be the length of the bladder. And the machine does a calculation, and it estimates the bladder volume. Pretty straightforward. We're going to move to the heart now and talk about the three views of the heart you guys learned: parasternal, apical, and subxiphoid. The parasternal long, we aim the indicator towards the patient's left hip, getting a longitudinal view. The apical fourth chamber, we've got the indicator towards the patient's right, and then we slide down to the subxiphoid view, indicator to the patient's right. It's a bit of a clockwise pattern if I was to obtain all three of these views. Parasternal views I really get for contractility. Apical fourth chamber, I get to compare the chamber sizes, right versus left, and also valvular issues. And then subxiphoid, really for pericardial effusions and deciding whether somebody has pericardial tamponade. Obviously, there's a lot more you can do with the heart, but those are the basic things I want you guys to focus on this year. Now, parasternal long, you've got the indicator down towards the patient's left hip, and you're getting a longitudinal view of the heart. Here you can see the indicator here on the probe down towards the patient's left elbow or left hip. Every patient's heart is in a slightly different plane, therefore they have different axes on the EKG, but you get the idea. You're going to aim towards that patient's left. And when you do so, we get a longitudinal view of the heart, this being the left ventricle, aortic outflow tract, the left atrium is here. In the interventricular septum, you can see here, here's the anterior and posterior leaflets of the mitral valve, and the idea in a normal functioning heart is that that mitral valve comes up and smacks that septum. And what you're going to see here is just another sort of normal view of the parasternal long view of the heart, left atrium, left ventricle, aortic outflow tract. And if I back it up here, you might be able to see, it's not cooperating, but oh, here we go. Maybe if I can get it to come back here, and you can see how this, well, this mitral valve here wants to come up and smack that septum, which it's doing actually quite well. And what you guys are going to learn this year is dropping an M mode spike right through here, and you'll see on M mode how close that mitral valve actually comes to smacking that septum. The closer it gets, the better the ejection fraction is of the heart. Moving on now to the parasternal short axis, this is where we moved the probe 90 degrees from that left elbow. Now we're moving it towards the right elbow. So whatever view you found the best parasternal long in, you just move the probe exactly 90 degrees and you'll see the short. And you'll see several views of the short axis. You can see all the way down towards the mitral valve called fish mouth view, or up towards the aortic valve, or down towards the apex where you'll see some of the papillary muscles. And just to put all three of these together for you, you can see that now here. We see the short axis at the level of the papillary muscles here down towards the apex. We see the mitral valve here, and then the aortic valve down here. And so when you can see all three like that, you can't see all three on the screen at the same time just because you're cutting it in three different planes. But clearly this is a short axis. You get the sense that we're doing a transverse plane. Notice how we don't say transverse anywhere when we label the heart in a short axis. We say short axis because, again, the heart can lie in many different planes. So just use the word transverse, it wouldn't make sense. But short and long axis is how we think of that. And you can see right there the papillary muscles come together really well. It's almost like the heart is a donut coming, and there's the center of the donut here. You like to see the entire heart all squeezing equally towards the center with good contractility. Now, just another example here of the short axis down at the level of the mitral valve, aka fish mouth view, and we can see all the way around this heart. Here's the septum up here. We're not getting a lot of good contractility as opposed to what we saw in those previous hearts. It doesn't have that really nice squeeze to it, but it is symmetrical, and this would be the center of the donut. Another example here of a parasternal short axis. This time we're up at the level of the aortic valve, and if you catch it just right, it can look like a little Mercedes-Benz sign. The three leaflets can be seen there, those tricuspid aortic valve. Okay, moving on to the apical views, and I can tell you that the apical views of the heart, definitely the most challenging to get. Maybe they're not that hard on some of the standardized patients that we have, but once you start moving to people with a larger and larger body habitus, then you will find that this can be a very difficult view. So what I tell the patient to roll over on their side and move into a car model position as if they're going to model on top of a car at a car show. Immediately, for whatever reason, everybody knows exactly what that means. They roll over on their side, put their hand above their head, and we get to work. And so what you're going to do is you're going to feel for that point of maximal impulse. That's the dime-sized area on the chest where the heart comes to the chest wall, and that's exactly where you're going to plop the probe on the chest with the indicator towards the patient's right. And this is exactly what we see here once we get it done right. The septum stands straight up and down, and the sound is going right into that left ventricle, and then eventually the sound also makes its way all the way down the left atrium. The sound is also going through the right ventricle and into the right atrium. And what we're seeing here is a comparison of the right side of the heart, which should be about 2/3 the size of the left side of the heart. What you're going to learn this year is some pathology related to chamber size and RV strain and things of that nature. Look at the contractility, and you can see the wall thickness here, and you can also make out the valvular function as well. We put color flow on these valves and to check for any regurgitation in this view. It's a very parallel view, which works well with Doppler. And we can see here a couple of other views from some examples here of an apical four-chamber view. We can see the right and left ventricles quite well in both of these hearts seen here. Now, when you get to the subxiphoid view, that's where you come around. It's kind of the final view of the heart if we're doing the clockwise motion, and we're using the liver to see the heart. It is a four-chambered view of the heart. The trick, this can be also quite challenging to obtain, especially when somebody has a small liver. But the way you do this trick is you look straight towards the liver, and then you never cross midline. You drag the probe a little bit into the subxiphoid area here. Sound's going to go towards the chin. You don't aim it towards the left, and because otherwise you're just getting air and you won't be able to see the heart. Subxiphoid view here, we can see the liver at the top of the screen, right ventricle, left ventricle, right atrium, left atrium. There's a pericardial effusion seen on this heart as well, and there's the chambers. And you can see the valves as well, tricuspid and the mitral valve, and even that hyperechoic structure there, the pericardium. So again, we have the, just as a review, we put the probe next to the sternum, and if we aim it, the indicator towards the patient's left hip or left nipple, we get the parasternal long. And then we rotate the indicator towards the patient's right elbow or right hip, and we get the parasternal short. And then we move it underneath the left nipple, roll the patient on their side with the indicator towards the patient's right. We're getting the apical forechamber. And then we slide it down to that subxiphoid area there, using the liver as our window, and we get the subxiphoid, sometimes called subcostal view of the heart. Okay, now we're going to talk about the gallbladder. The trick to the gallbladder is to have the patient take a deep breath and to roll the patient on their side. If you roll the patient left lateral decubitus, you get a much better view of the gallbladder because the duodenum kind of in loops of bowel along here fall out of the way. This is the fundus of the gallbladder, this is the body of the gallbladder, and we can see the neck down here. And when you learn about the pathology of the gallbladder, you're going to be looking for stones all the way down here in the neck, as well as the body, and sometimes up in the fundus. So the way to do it, to determine that you are definitely looking at the gallbladder, is to find the main interlobar fissure, which connects the portal vein and the neck of the gallbladder. We can see that hyperechoic line there. And here's another example of a nice hyperechoic line, the main interlobar fissure of the, it's where the right and left lobes of the liver come together. And it's a nice landmark, because sometimes you see these circles on the screen, you're like, okay, which one's my gallbladder? Well, portal vein has a very hyperechoic wall to it. There's your MILF, and then there's the neck of the gallbladder, and you can see the gallbladder stretch itself out. This is a very contracted gallbladder we're looking at here. Again, just another example of the main interlobar fissure seen very nicely there. Very good. Now, once you get the gallbladder in the long axis, then you're going to rotate 90 degrees into the short axis.
Once you instate the gallbladder in the long axis, you
Dr.
also
Will
need
Scruggs.
to view it in the short axis.
He is the president of
Once
Hawaii
you do get the
ASAP.
gallbladder in the long axis, you're going to fan through
He's president
the
of the Hawaii
gallbladder,
American
like
College
so,
of
making sure
Emergency
you catch the
Physicians, and
entire
he lives in
gallbladder,
Hawaii, one of
looking
my
for
prior
any type of
fellows.
pathology. After you're done with
He's
the
got
long
a
axis, you're
great
going to
voice
rotate the probe
for
90
ultrasound,
degrees
and
from
he's going
whatever
to
axis
rotate that
you're in,
transducer
like so.
into
You're
the
going
transverse
to view the
plane.
gallbladder in the short axis.
Subcostal view. Patient
Again,
takes a
you're
deep
going to
breath,
fan through the
and
entirety
you
of the
just fan
gallbladder,
through the
looking for
area.
any possible pathology.
Nicely done, Will Scruggs. We have that short axis of the gallbladder seen here on some of these views. You can see it here. It's the most anterior or closest to the skin line anechoic structure is how I think of it. In larger patients, sometimes we need to go more laterally, what we call the X-7
patients, we tend to
position.
find the
Will describe it to
gallbladder
us.
more lateral and anterior. In those patients, if you can't find it with the subcostal sweep or the X-7 approach, it's often helpful to take the indicator and really flatten it out against the abdomen. The indicator is pointed towards the patient's right. The probe itself is flattened out as much as you can. You kind of fan through the gallbladder anterior to posterior as you work your way laterally. And oftentimes you'll find the gallbladder up in this area here.
So he just described the subcostal approach. The X-7 position is for larger patients. This is where, you know, the xiphoid process, and you move laterally. And sometimes you go between the ribs, use a smaller footprint probe. This is where he describes that technique.
In the X-7 approach, the X stands for the xiphoid process. The 7 stands for the 7 centimeters. You're going to go to the right laterally, place the probe perpendicular to the patient's skin, and more often than not, you're going to find the gallbladder in this general area.
So getting between the ribs is the trick sometimes on larger habitus patients, and you get a lot more lateral, almost into where the position where you do your fast scan and you're looking at Morrison's pouch. If you see the kidney, you're really lateral, or I should say you're really posterior. You might want to come a little more anterior to get to that gallbladder then. The gallbladder is in all kinds of funky different locations in patients, and it really is the art of sonology. It will challenge you. However, it is also very satisfying when you can see it, whether you're in the coronal plane, transverse, or sagittal plane. Moving on now to the leg veins, we talk about a common condition that we see all over the hospital in many, many different types of clinical scenarios, which is deep vein thrombosis, which is a blood clot in one of the deep veins. As you know, that blood clot can migrate to the lung and cause a pulmonary embolism, even a fatal pulmonary embolism if it's large enough. So we're always thinking about this in many, many different clinical settings. And you can see the structures here, the paired arterial and venous structure, the nerve being the more lateral aspect. How do you remember that the vein is the more medial aspect? Venous rhymes with penis. So venous, penis, that's how I can remember that orientation. I know there's less, more professional ways to think of that, but in the heat of the battle, that is always something that I can remember. And because sometimes you're upside down, you're trying to put a catheter in this vein, and you know, you're looking at the machine the wrong way and everything's getting all confusing, but that always kind of grounds me. You could also say venous vagina if you'd like. Now what you're looking at is these, as the vein comes out of the inguinal ligament and down the leg here, we're going to track it all the way down as far as we possibly can, looking for a deep vein thrombosis. The deep femoral vein eventually dives deep and goes towards the femur here, and when its caliber starts to really decrease. But in its initial component here, about a third of the way down the femur, maybe a little less than a third of the way down the femur, it does have a pretty large enough caliber to cause a clinically significant DVT. So you want to locate both the common femoral vein as well as the deep femoral vein as you're doing your compressions coming down the leg. The saphenous vein is very superficial, and sometimes you'll see a superficial clot up here in the saphenous vein. But where that saphenous joins in the femoral vein, that's where I start. And then I start making my compressions, and I go distally here, 1 centimeter increments going down the leg. And eventually you'll see this. So which leg is this? If venous rhymes with penis, this must be the, indicators to the patient's right, this must be the what leg? Good, the left leg. And so common femoral veins, superficial and deep femoral arteries here, and you're going to start making your compressions. And again, you're going to go all the way down the leg through that superficial femoral canal until you get to the popliteal area. And then in the popliteal area, what you're going to see is that the vein comes to the top in the pop, which means that the vein is more superficial because you're looking from behind the knee. You can see the popliteal vein coming down here, and eventually it bifurcates and trifurcates and quadricates, and then somewhere in here you're going to get all the way down until you start to, until these veins get very, very small caliber. An example here I drew on one of my fellows, Matt Solly, is the bifurcation here of the popliteal vein. And again, you're going to put the probe here in the posterior fossa, put your hand on the patient's knee, and then squeeze your arms together. And we can see saphenous vein, common femoral artery. Therefore, this must be the, which leg? Good, right leg. And then this is before compression, and then with compression down here, the artery stays open. So the vein walls, this is called coaptation. Coaptation is where the vein walls come together, and therefore we know that there's no clot there. So this is another example here of coaptation of the venous walls. At this location, there is no clot. You can see here, however, when we do compress, there is lack of compressibility. The vein walls do not coapt, so therefore there is a clot seen here in this vein, in the common femoral vein here. Now, when we're down in the pop, again, we're compressing, and the vein comes to the top in the pop. The artery's down here, the vein's up here. Nice coaptation tells us there's no clot. And to show you what a clot looks like, this does have a lack of coaptation here, failure to wink back, if you will. The artery's down here, the vein comes to the top in the pop. This is a DVT. So the question is, this question comes up all the time, and I just want to briefly bring it up as we move into more pathology in your second year. Some of my colleagues in emergency medicine have noticed that if you failure to look at the deep femoral vein, that's that bifurcation off of the femoral vein, and failure to go down into what we used to call the superficial femoral canal, but it's this portion of the femoral vein that's kind of distally. It's distal to the branching off of the deep femoral vein, but it's, you know, proximal to where the popliteal system is. This area here, folks were missing some clots. So if you add up the deep femoral vein and you add up this area here, you get to 6.3% of the time you could miss a clot that wasn't up in the common femoral and the popliteal system. So the take-home message is come all the way down the leg and get into this area that's hard to insunnate as best you can so you don't miss a clot in here. So that's the main conclusion. I would say come down the leg as far as you can into this superficial femoral canal, or adductor canal it's sometimes called. There's some more fibrous tissue in here, makes it a little bit difficult to insunnate, but that's your goal. Come down as far as you can, and then also do the pop as much as you can. Changing gears now to the aorta. You guys learned that the aorta, as you go from, this is a sagittal view here, as you go from proximal to distal, the vertebral bodies get larger and larger, and the aorta gets more and more superficial or anterior. If I was to remove the liver and the intestines, you would see the aorta coming just to the left of the spine as it's making its way down to the abdomen into the bifurcation to the iliac vessels. And we can see some of the vasculature here come off in the upper abdomen, namely the celiac axis and the superficial, as we're coming down the abdominal aorta here, we can see the branching off. The first branch off the abdominal aorta is the celiac axis, which brings blood to the large organs in the upper abdomen, namely the splenic artery, and then eventually the common hepatic artery. And then distal to that, you'll see the superior mesenteric artery branch off as the second largest branch off the abdominal aorta in the upper abdomen, bringing blood to the intestinal structure. So we can see that here. Here's the sagittal view here of the aorta. We see both the celiac and the SMA coming off in that sagittal view. The duodenum is seen up here, with some material in it here adjacent to the liver. People always see this duodenum and wonder what it is. So now you know what it is. That's the duodenum. In a transverse plane here, we see the vertebral shadow. We see the aorta. And I see the IVC adjacent to it. Here's my SMA here, superior mesenteric artery, and then above that superior mesenteric artery at this plane, we're seeing splenic vein crawl over that SMA, and this is all the liver seen up here. And the left renal vein gets nut cracked between the aorta and the SMA, making its way over here to the IVC. This was an ultrasound that was done, I don't know, maybe a couple of weeks ago, 3 weeks ago. One of my colleagues working in Catalina, and a person had come in with a syncopal episode, and she performed an ultrasound there just to rule out a AAA, even though the guy was essentially asymptomatic, other than having a syncopal episode where he immediately woke back up. But just to get checked for passing out, he came into the ER over there on Catalina. It's a 2-bed ER, critical access hospital. When you're working there in the ER, you're the only doctor on the whole island. And this is the kind of thing that ultrasound really lowers our threshold to pick up life-threatening conditions. So this is an aortic aneurysm, and it's roughly, 7 centimeters or so. You can see some blood swirling around there here in the transverse plane. It just obviates the reason why I think how ultrasound really helps me, in this case, helped my colleague lower her threshold to pick up a AAA. Well done, Dr. Osborne. Here you see here, now we're not talking about the aorta anymore. We're talking about another tube that runs next to the aorta, the inferior vena cava. And we use this to approximate the central venous pressure in the body. So we can see it really easily here floating across the screen. And there's a little circle back here. I don't know if you can see it as well or not. Once in a while it pokes its little nose into the IVC. It runs posterior but perpendicular to the IVC. This is the right renal artery seen down here. That confirms I'm definitely looking at the IVC and not the aorta. Sometimes the IVC and the aorta in a sagittal plane, hard to tell them apart because you don't see them both at the same time. But if you just go parasagittal to the patient's right, indicator towards the patient's head, you'll get the liver, and then posterior to that liver should be your inferior vena cava. And the inferior vena cava is nice because as the patient takes a deep breath, the IVC flattens down. And if it really flattens down, we know the patient's got low intravascular volume because we see collapsing of the IVC. However, if the patient takes a deep breath and there's really no or just very little change in that IVC diameter, then we know that they have a relatively higher or normal central venous pressure. So let me show you some examples of that. This was, some people think if you have a really low IVC, small pre-inspiratory IVC, and the whole thing collapses down, then your pressure in your right atrium is very low. And as the IVC grows and the collapsing is not as much, then the pressure in your IVC gets higher and higher. It turns out that these values in the middle range here are probably hard to really confirm, but when you get to the edges of this, definitely this is low intravascular volume, and this is very high intravascular volume down here. And those are the two extremes where I love to use this. Another example here of just the IVC coming along. This time we have color flow on it. We can see that right renal artery, running posterior but perpendicular to it. Portal vein is lighting up with some color flow here as well. And the blood is just making its way back to the heart. This is a relatively plump IVC. I would say this patient's got, if I'm worried about volume resuscitation and giving this patient more fluids to bring their volume back, I would say here we're doing pretty well, the volume resuscitation. This is a large IVC and it's not compressing, or I should say collapsing, and it's definitely more than 2 centimeters. However, this is a very puny looking IVC. It's like pretty much collapsed all the way down. As the patient takes a deep breath, you can see it almost the walls touch. So this is somebody who's under resuscitated. We use this IVC as a marker to give more fluids because they have a low central venous pressure. And in setting of hypotension, this is a good place to start with volume resuscitation. Another example here of an IVC, you can even see the hepatic vein draining in here. When you see a big plump hepatic vein like that and a big dilated IVC, this is a sort of a plethoric looking picture to me, a very dilated plethoric looking high central venous pressure situation. Now lastly, we're going to talk about we talked last year about the thyroid. Medical students love the thyroid. I see this all the time. When you guys come in your 4th year to scan with me in the ER, you come back with all these beautiful thyroid pictures. So which is amazing. But this is the isthmus of the thyroid seen up here. You can see the right thyroid over here and the left thyroid over here. This is the trachea seen here. And then when you go to the sagittal plane with the indicator towards the patient's head, you can see the thyroid glands stretching out across the screen. And I gotta tell you, thyroid looks exactly like testicle. Very similar type of glandular tissue, I think, is the reason why. But when you get the plane just right, you can even see the vasculature running through the thyroid. And you're going to learn this year a lot more about some thyroid pathology, thyroiditis, thyroid nodules and cancers and things like that. So it's going to get a lot more fun this year, I think, for you guys. And then finally, we did talk about the eye last year. Just to review the anatomy of ultrasound, ocular ultrasound here, you can see the eyelid. After you put a big glob of gel over the closed eyelid, you can see the eyelid, you can see the anterior chamber of the lens, you can see the iris, and you can even see pupillary contraction. This is your posterior segment where a lot of the pathology comes into play that we can see on ultrasound that you're going to learn this year, such as retinal detachments, posterior vitreous detachments, and vitreous hemorrhages. And then that's where the retina is back there, attached down to the choroid, and you can see the optic nerve sheath coming down there. All right, now go scan some organs and make me proud. See you guys soon. Bye-bye.